So the next session we are going to have is from Dr. K Srinath Reddy, and he's a born leader. Okay, and there are certain qualities which I admired him as a junior resident, senior resident, faculty. Is something great. He would not realize it. Way back, 30 years back, my mother was admitted in one of the private wards, and we sent a referral to him. And 99% of the cardiology consultant, they should send their senior resident to attend the referral. This gentleman always came. For him, the commitment to the profession was at the highest level. And that is how he has followers like me who are always admire him. So leaders is not only the leadership, it's the overall quality, I personally feel, which makes a person leader. He doesn't have to be commandant to do everything. For me, he's a great man. So the idea of this session is, Meet the Leader session is, that you tell us about how you have reached this stage, the peak of your success, what lessons you would like to share it with these participants, what errors you might have committed in your such a long, beautiful journey. And one more question from my side. They will ask many questions to you. One more question from my side. You being such a successful cardiologist of All India Institute of Medical Sciences, you had everybody on your patient list, Prime Minister, President, Governor, this. Why did you leave the cardiology and started public health? And your public health foundation is contributing a lot in the country. It has contributed a lot. It is contributing, and we pray that it contributes more and more in future also. So with these words, we have an hour with you, sir. And please help us out. And I request all of you to shoot as many questions to sir. Okay. That how come he is so successful? What is the secret of his? He is intelligent. That's a separate issue altogether. But there are so many talented people, they are not successful. So with this, sir, over to you.
Thank you, Professor Kapil. I'm not sure how the session with Professor Dr. Renu Swarup went, and I do not know how you want me to structure this session. But basically, let me speak a little bit about myself from the point of view of the question that you posed. What made me transition from cardiology to public health? And then possibly try and take more questions than actually try and provide too much of a perspective from my own position here. I got into medicine partly because of my father. So I'll have to reflect a little bit on my own life story. My mother was a professor of obstetrics and gynecology. And she was a very active practitioner, but she focused a lot on helping poor people, particularly those who had vesicovaginal fistula, women who were rejected by their own families because of the obvious incontinence of urine and dribbling. But she focused a lot on working with them and helping with them. But otherwise, she was an obstetrician and gynecologist, and she worked all the time in government hospitals as an honorary doctor in Hyderabad, where honorary system prevailed. She had a private clinic, not a nursing home, but there again, she used to actually treat poor patients completely free of cost, and not infrequently used to pay them to get back to their place, even with their transportation costs, because she believed in that principle. My father was a lawyer and trained as a lawyer, but also was passionately interested in sociology, political science, economics, and economics was particularly a passion for him. And house was full of books. I'm an only child. So for me, it was easy for me to find company in the books. And I used to read a lot of books that my father used to have. So I was impressed by the number of things that I read. But I also happened to have been uh, a debater at the university level in Hyderabad, in capturing this Usmania University. I was underage for medicine, so I had to do one more year of BSc, and that is the time I spent debating, etc. So I got my interest in social sciences, political sciences, and economics from my father's library and also from my debating. So I said, I'm going to take up this as my line of career. My father, who was a lawyer and an economist, said, I don't think that would be the right decision for you. I said, why? He said, look, these are things you can always learn on your own. Whether it's English literature or social sciences, you can always read. Economics may be a little more difficult, but you can still do a lot of self-directed learning. But if you want to be useful lifelong to society, you have to get a professional training. And as a doctor, you can actually be useful till the last day of your life to society. And for that, you need a structured professional training. So why don't you take up medicine? Rest of it, if you feel interested, you can read all the books you want and gain your own knowledge. But for a professional training, you need a structured education. So he persuaded me, and I took up medicine. And I graduated from Usmania Medical College and then came to Delhi for my further education in MD medicine and DM cardiology. My introduction to AIMS came when I came representing Usmania Medical College in intermedical debate, and then I saw this grand institution, the AIMS, and was totally fascinated. And I said, okay, if I'm going to do my post-graduation, this is going to be the place. About 90% of my classmates, believe it or not, from Usmania Medical College, ended up going abroad, either to US or to UK or to Gulf or somewhere else. And I was one of the few, though I did rather well in my MBBS. I said, no, I want to be here. I said, I'd rather work in India and visit the West rather than live in the West and visit India, because I'd like to be relevant to this country and feel I can be useful to this country. Partly the values that I think my parents passed on to me, but that's how I chose my career. But then once I chose my career, I said, if I'm going to study in India, I'm going to study in All India Institute of Medical Sciences. Fortunately, I got a house job, then got selected for post-graduation, and then did my MD medicine. Then came a very interesting conversation again with my father. I was fascinated with immunology. My first house job was in cardiology, by the way. And then I liked cardiology very much when I was going through my MD medicine training. And I was liked by my cardiology faculty, Professor Sujay B. Roy, Professor Emal Bhatia, etc. Because one of the things that my training in Usmania Medical College taught me was to be committed to patient care, and that clicked with these people. So anyway, there was a choice whether to try for cardiology or after my MD medicine or immunology, which I was greatly fascinated. But then my father again asked me, do you want to go abroad and settle down, or do you want to stay in India? I said, no, I feel relevant here. I want to stay in India. He said, if you want to do something in immunology, because that was way back in 1970s, he said, you will have to depend a lot on very advanced laboratories. India doesn't yet have that kind of advanced scientific facilities. If you want to do something good and achieve something in immunology, you might have to go abroad. On the other hand, in cardiology, you can be very much here and be very useful and be very competent and not feel the pinch that you do not have adequate support in terms of equipment, etc. is essentially he was trying to brainwash me into staying back in India, which succeeded because I said, okay, I understand. Um, and I chose cardiology, which fortunately I got selected in too. And I loved cardiology, and I was very happy with my work in cardiology at the All India Institute of Medical Sciences. But all through, I was conscious of the fact that what we do in hospitals, while it's extremely important, it's still inadequate to deal with many of the health problems of this country, even in cardiology for that matter. While a young faculty member in cardiology, I was asked by Professor Amal Bhatia to be part of a three-center project, multi-center project funded by ICMR on community prevention of rheumatic fever and rheumatic heart disease, primary and secondary prophylaxis. Varanasi, Vellore, and Delhi. And I was asked to coordinate the project and be the sort of gold standard for clinical standardization and so on. But when you go around villages in rural India and in the three centers, you see where school children are coming from and trying to test them for, evaluate them whether they have murmurs or not. Or if you're sitting in the ward in cardiology in All India Institute and finding people coming in from very poor families, hardly able to afford treatment by way of valve surgery, or even not even able to get regular anticoagulation checked after we have put in valves and going back to the villages and coming back with clotted valves, you realize that professional competence alone is not enough. There are so many social determinants which influence the course of medicine and medical care. So I was always sensitive to that. But I also wanted to do epidemiology to find out what's happening in a period of transition when not only rheumatic fever and rheumatic heart disease, but cardiovascular disease was now manifesting as coronary heart disease in a big way. And then I went in for training in cardiovascular epidemiology initially, and then in epidemiology in McMaster University, while working as a faculty member in AIMS. And was the PI of a major multicentric study again between Delhi and Vellore on looking at urban-rural differences in prevalence of coronary heart disease and risk factors of coronary heart disease. So that particular element also came in, that I wanted to do more on prevention rather than just on clinical care. So public health interested me, but of course I was a practicing cardiologist and enjoyed every moment of clinical care as well. At some point in time, I decided I must get more formal training in epidemiology. Went to, at that time, there was an opportunity by way of what was called the Incline program, which just started in India, where from 6 institutions in India, people were being sent abroad for training, and clinicians were being sent abroad for training in epidemiology. So I went to McMaster University in Canada, got my MSc in epidemiology there. But it was also an eye-opener for me to see that there was so much of multidisciplinarity there. And I said, public health has to be much broader. And therefore, it has to involve health economics, social sciences. It has to involve, of course, epidemiology, biostatistics, all of that. Why is it that in India, we are not seeing that happening? I know that there were programs definitely in medical colleges and community medicine, which are very good. But somehow the engagement with health systems and health policy was not as much as it should have been. So why can't we create institutions which have a very strong multidisciplinary basis for education and research, but which also connect very strongly with health systems and health policy? Of course, there were honorable exceptions, but we thought we needed more institutions. After all, Bangladesh had already set up the Grant School of James Grant School of Public Health. Thailand already had it. A number of countries in our own region had it, but why is it that India didn't have it? So at that time, there was an initiative to consider whether we should actually have these kind of new schools of public health. And it was suggested that as Public Health Foundation of India should be started. So this was a time when I had already transitioned to become the head of cardiology in All India Institute of Medical Sciences. But we were advocating that we should have schools of public health. Even in our aims, we felt it was needed. But the government of India took the decision that they will try and encourage a public-private partnership, which will bring in both public sector and private sector, because they said government money will be mostly spent for medical colleges. Unless the private sector also joins in this initiative, we'll not invest money. And we will encourage a foundation to be set up, which will set up several institutes of public health with multidisciplinary faculty and for multidisciplinary education and research. So that's how the Public Health Foundation of India was conceptualized by the Ministry of Health at that time. So that was a time when I was asked whether I would head the institution. I was head of cardiology and had a reasonable opportunity to grow in that career track in the institute. But I felt that since I've already sort of canvassed for new institutions in public health to be set up, advocated very strongly, I should take up the responsibility. I did take up the responsibility. But one of the things I must say, and I'm not saying it essentially to position myself in a positive light, but one of the things that in life you must decide is you have to make choices. They're not easy always. Just as I said, I was very fond of immunology, but I gave it up for cardiology. There are other times when you feel there are other opportunities that arise, but you have to reason for yourself as to what you really want to do and where you can possibly make a difference. So I did leave the tried to set up several institutes across India. We right now have 6 actually, 5, and the 6th one is under development. There's a full-fledged university in Gandhinagar, a second one coming up in a permanent campus in Hyderabad. In Shillong, it's a government-provided facility. In Bangalore, it's a government-provided facility. In Bhubaneswar, again, from a temporary campus to a permanent campus, the transition is happening. And the Delhi one, which was actually in Gurgaon, is now moving to Delhi again. So there are institutions that we have set up. But more importantly, I think we help to catalyze also interest in medical colleges, the new AIIMS-like institutions, as well as universities to set up schools of public health. So that, I think, was a catalytic effort that the foundation really managed to do. Now, the question that was posed to me was, what made you move? Dr. Kapil asked. Well, as I said, you can always look at it from the point of view of the individual patient, and that mattered a lot to me as a clinician and still matters. But you also realize that you have to do a lot to prevent disease and to create systems which can actually even provide better care for disease. And that is where public health comes in. I see public health not merely in terms of prevention and health promotion, but also in terms of building stronger health systems. And that is where I believe we need to really create efficient, equitable, and empathetic health systems, even to provide better clinical care. Therefore, if somebody asks me, not necessarily, people who are leaders of the profession like you, but somebody, a layperson, asks me, why did you shift from public health to from clinical medicine to public health, I say that clinical medicine delivers health in retail, public health delivers health in wholesale. So you're dealing it at population level, and therefore you're actually doing that. Both are very complementary, obviously. And fortunately, I had the good fortune of living my life in both those domains. So that has been helpful. One of the other things that actually cemented my commitment to public health, apart from my training in epidemiology, was not only the field experience, but a lot of engagement with policy and advocacy. I got involved with tobacco control related advocacy even while I was in All India Institute, very much so vigorously trying to build a campaign for tobacco control. And that led me to be part of the international negotiations on the Framework Convention on Tobacco Control, because I was chosen by Government of India to be a member of the Indian delegation. And that was a very rich and remarkable experience, where not only the bureaucrats are there from the health ministry, but sometimes you also get people from foreign ministry or the embassy. And each delegation from abroad has experts in finance or foreign affairs and so on. And as a technical delegate, you again are representing your country. And sometimes I had to actually become the spokesperson for India, for Southeast Asia, and for a number of developing countries to negotiate at that level and to take on governments like USA and Japan and others who are very much favoring the tobacco industry, and fight them to get a very strong treaty was a remarkable experience. Fortunately, Mrs. Sushma Swaraj, who was the health minister here, was also pushing the Indian treaty at the same time, and there was strong backing from her. So we could, at the international level, negotiate. But that experience was, again, an important experience in trying to make public health much more connected to policy change. So I did have that privilege as well. And subsequently, the question of whether I make the transition to Public Health Foundation of India or do something else came up. And I was asked by the then Health Secretary, Mr. P.K. Hota, that you have two choices to make. Either you can become the Dean of the Public Health of All India Institute, because at that time the deanship was open, or you can become the President of Public Health Foundation of India. I said, so there are many people who are lined up to become the dean, and I'm sure they'll do a great job, but I'm not sure there'll be many people who want to head the Public Health Foundation at this point. So I'll make that choice. Therefore, the question was, where am I more relevant? Where can I do more, which others may not necessarily be ready to do? So I think that's an important consideration when you make your choices in life, where you can make a difference and where you can contribute usefully. Again, partly with Chatham House rules in this room, not to be quoted very widely, such occasions came up repeatedly in life, where you have to make choices. Soon after my becoming president of the Public Health Foundation of India and leaving my position in All India Institute as head of cardiology, I got a call from Professor M.K. Bhan, late Professor M.K. Bhan. He said, the head of ICMR position is vacant, and this is Secretary Health Research. You should apply. So I didn't apply. So he called me up again. He said, "Tune apply nahi kiya." I knew him very well, so he could take a lot of liberties with me. So he said, "Tune apply nahi kiya." Nahi sir, kal last date kar do. I said, "No sir." He said, "C.N.R. Rao is the chairman of the committee. I'm a member of the committee, and we want you to apply." I said, "Sir, मैं नहीं कर सकता." कारण बता दे. ऐसे सर 3 कारण है. First is there are a number of people who will want that position, and I'm sure that position will be filled by some good person. But I don't see right now anybody who wants to fill Public Health Foundation of India presidency, and I've taken it up, and I don't want to leave it right now. Second is I've just sent about number of 24 people abroad for training, young people for training in international institutions. We realized that there were not enough public health trained professionals to become teachers in India. So we negotiated with international institutions, some of the best schools of public health abroad, and we sent people abroad for sponsored training. I said, I've just sent them out, and if I now leave, they will feel I've betrayed them. I can't do that. And third, I said, I'm courteous by nature, but not a courtier by nature. I don't fit into the corridors of Nirman Bhavan. I'm saying this without any disrespect to people who have occupied positions in Nirman Bhavan. That's very good. But temperamentally, sometimes you have to be very careful as to where you feel you can fit in best. But I had to deal with Nirman Bhavan afterwards as president of Public Health Foundation of India. I had to deal with so many state governments. I had to deal with multiple governmental agencies. And it's not you have to learn on the job. But at that point in time, I said, let me take up the PHFI as a position. Around the same time, I got an offer from Harvard for a full professorship, tenured professorship. The first Bernard Lown professor of global cardiovascular health. It was tempting, but again, the question was, how can I abandon something that I've just picked up? There's a commitment I've made. Secondly, where am I more relevant? If I go to Harvard, I'll be just another professor. Maybe I'll learn a reputation, I'll publish papers. But mere bina bhi wahan pe kaam chalta hai. Whereas here, I've undertaken a new initiative in India, and I feel I can make a contribution. So I feel I'm more relevant and more valuable here. So I mentioned this to the Dean of Harvard School of Public Health, and he understood, and then they converted it into a visiting professorship, the first Bernard Lown visiting professorship in global cardiovascular health. So the question is, you have to make your choices based on 2 things. One is, what are your commitments? And secondly, where do you feel you can contribute most? So if where you feel your aptitude is and your competencies are, and where you can put your heart in, that's where I think ultimately you can do best. And that is where you have to make those choices, irrespective of the temptations of, being called DGICMR or Secretary Health Research or professor in Harvard. I think that is the critical element that is important. But I feel I have, in the Public Health Foundation of India, had a great opportunity. I've been a clinician, and I enjoy being a clinician. Even now, if somebody wants a bit of advice, I offer it pro bono. Happily, because that little gratification is there, emotional gratification is there of getting somebody's blood pressure under control or something like that. But I don't actually get into active clinical work now. But public health, education, policy, training, all these are important elements. So those dimensions of life will continue. But building institutions is critical. Many of you have built institutions or contributed to institutions' growth. But building these institutions of public health is a very, very important task, which I felt must be done. And therefore, to have now one full-fledged university in Gandhinagar, another one coming up in a permanent campus in Hyderabad, and 3 others in different parts of the country, and probably a 6th one coming up in Bangalore, I believe is something that I can feel happy about looking back on what I've done. But again, these are matters of choice. You have to make those choices and then continue to have commitment to the choices that you've made. Otherwise, you can easily get distracted. So that is my story. So I don't know whether I've answered Umesh, but the reason I said is very clear, that we can deal with disease only to a certain extent as clinicians. Clinicians are needed, no doubt about it. But if we really want to reduce disease and suffering in society, we have to really take on a public health dimension as well. And there is a continuum of both. I mean, after all, if we are really talking about somebody coming up with a clinical problem in a hospital, we must also ask the questions, what led to this disease? Were the systems efficient to prevent it? Were the systems efficient to pick it up early and refer to the hospital without much delay? And after the clinical consultation takes place, are the systems efficient in order to make sure that the necessary drugs are available at affordable cost? Can the person get the nutrition that is needed for recovery? Is rehabilitation service available? Or if it's infectious, are sufficient facilities available for isolation? All these are issues that come up, and palliative care, all of these. So I think public health and clinical medicine are part of the same continuum. It's not as though they're different worlds. And therefore, I'm not unhappy to have made that transition because as a clinician at heart, I'm happy when public health can create strong systems. As a public health person, I'm very happy when individual patients can get the right care. Long-winded answer to your question, Kapil. Right. Sure.
Supplementary है, ma'am. Sir, if you look at the country scenario, all the NGOs which are established by very, very eminent people like Gopalan and other people, they could not sustain themselves. So my question to you is, how you are sustaining the 6 institutions, which are also part of NGO, if I'm not wrong. How you are sustaining these 6 institutions and they are flourishing? Thank you, sir.
You see, initially, the argument from the government came, central government, that we can't invest in schools of public health. Actually, we said, you should set up schools of public health. In fact, even in All India Institute, we said you must set up a school of public health. But they said, no, government funds will go into new medical colleges. So unless there is a public-private partnership and the private sector is coming in to put in money, we will not undertake this exercise. So first thing was to convince the private sector. तो आप भी हाथ मिलाइए सरकार के साथ. And the way we argued was that, look, unless health of the country is protected, the economy of the country will not be protected. Your own profits, your own growth will not be sustained. And that we have seen what has happened in COVID also. That's a clear-cut example. Every time, the economy will keep slipping on the banana peels of public health failure. So it sort of clicked at that time a bit. So we managed to get people to put in some money, philanthropy initially. And with the governments, we sort of said, you give us also facilities so that we can try and support you in strengthening your health systems. So that came up as an initial thing. But it continues to be the same campaign, same slogan. They're trying to convince both the stakeholders that it's important for the country. And that is how it is sustained so far.
Good afternoon, sir. Sir, I first met you in 1992. You had a joint conference of IAPSM and cardiology. And that was, I looked towards you. I thought this is a person who is a clinician and he is oriented to public health. But Later on, you have moved on. And when you were in AIMS, then I saw the tobacco, all the students coming there, large kind of work was visible. So it was still satisfying for me. But later on, when you moved on, I see the NCD management in the country, the program itself, the preventive measures, the promotive measures, the legislative measures, everything is wrong. And I am really frustrated about it. I feel that is a burning thing now. Public health, we have lots of MPHs in the country. I don't know what they are doing. Okay. In fact, when I am teaching my MD students, I feel there is some kind of competition with them. So I feel there is some kind of duplication. When School of Public Health are coming in medical colleges, I feel the departments are diverting their resources to School of Public Health and not doing, that is, clinical teaching, which is their major
Dr.
aim.
Kiran, can you be brief so that others can ask?
Sir, I don't know how you can be happy about it.
Ma'am, I don't see MPH and MD community medicine as competitive. I see them as eminently complementary. And I believe that we need many institutions training in public health, people in different aspects of public health, in order to advance public health in this country. Therefore, setting up some of these multidisciplinary schools, you see, one of the reasons why this came about, let's be very frank, the medical colleges were functioning under the Medical Council of India. So you had limitations to multidisciplinarity in the faculty and in the student population. How many health economists, how many social scientists, how many advanced epidemiologists were employed in medical colleges? Not too many. So you needed institutions which could bridge that. Universities were not at that time inclined at all to public health. So they were not interested in starting a new public health discipline. It's a recent phenomenon that they are now starting schools of public health. So from that point of view, we felt at that point that we needed multidisciplinarity without restrictions, imposed either by the Medical Council of India's short-sightedness or by the insularity of university systems. So that's how it came about. But I believe community medicine and MPH are all eminently complementary and they need not be seen as competitive. They should not be at all. And I don't think either should disrespect the other. The advantage MPH offers is that it offers an opportunity to people from other disciplines, non-medical disciplines also to come in and then contribute. And they do contribute. And particularly whether it is health economists or data scientists or social scientists, we need to bring them in as well. But community medicine has its own very strong tradition and strong contribution, and that should continue. Now, as far as the NCD component is concerned, I certainly agree with you that we need to do a lot more on NCDs. And that is where I believe collectively we should move far ahead, far. But I think now even the government is realizing that there is a definite health transition which has happened and is happening, and more should be done. So whether in the health and wellness clinics or whether in terms of the hospitals themselves, a lot more attention is going to be paid to NCDs. And the very fact that belatedly they have declared even in the last budget speech that they're going to start HPV vaccination, all of that is actually now beginning to bring a lot more attention to NCD prevention as well as care. I think we'll have to work together to ensure that this happens. And the commitment to NCDs and tobacco control has not waned, that much I can assure you. Though right now we are also working in the area of climate health.
I just want to give you a ringside view of the development of our Dr. Reddy. If you remember, when I met him, I met you in the ICMR guest house, if you remember.
Yes.
He had some queries. Queries about what? Primary healthcare. primary health center. If you remember,
Yeah,
sub-center and
yeah.
others. He didn't know anything about that. I'm just telling you. He knows your cardiology, but that was. And they meet. I mean, we came into contact. We came into contact for the rheumatic fever.
Yes.
तंदूर जो होटल था ना वहीं में किया हुआ था. Dr. Ganguly was there who came for the and in Bardhaman, I mean, there was something. He was not involved in that. So I just had a discussion with him. Why? What is the program? Because we are discussing in the ICMR, but it is not being implemented in the policy. So that's the thing. The second thing I tell you, there are 3 persons who went for the Incline project. One is himself, the second is Narendra Arora, and third one is Chandrakant Pandav. 3 of them has made the leadership qualities. I tell you, he has got the information from me. I was an outsider. I was from Assam. Just I used to come in the but he came down to me, and we spent hours together, if you remember.
Yeah.
And then Chandrakant, what he did a good advocacy. IDD, he's an IDD man. He's a public health man. See the contrast. The third one, Arora, he's a vaccine man. So what is that? We get the training. I'm just giving we get all the training. We go abroad, get the training, leadership training you will be taking, but you will not be implementing it the right perspective. The next one is, I tell you, when they started it. I mean, when he started, why he has joined. He had another project. You remember? Cardiovascular problem all throughout the India. You have a preventive package also. None of the community medicine developed it. None of our professors of community medicine developed it. He is the person who developed it. And that was model which has been taken up. I know.
Dr. Farooq, what is the question?
Not the question. See, I am giving you a ringside view. Ringside view, because a leader, all the qualities of a leadership is here. Now he has chosen public health, not the other critical one. When he has chosen, it is the advocacy, what he has done, that he has brought up a public health institution, public the system itself, a system itself. So that's what I am talking about. Now it is not only related to, see, I mean, it's an instinctive thing, the changes. He has changed a lot the day I saw him first, and the change after this. For the recruitment of who will be the person is assisting him from the community medicine. So he asked me, who are the good persons? So automatically, he has taken the right choice. There was Professor Thankappan, though I should not take the name. There are a few, we had a discussion, but he took the right person. Now the person, who is there. He has built up a team, not only for his institution, but build up a system itself. So that is the great thing. And not only that, he has not only related to, what is that called? Public health. His contribution to medical education, no one knows in the Lancet group. Now we are talking about system-based medical education, isn't it, sir? So he is a contributor of that. So automatically, see, the
The
leadership.
message I am getting is these 3 people were exceptional leaders, and that is why all of you are
That's
there.
it.
So to move up and become influential in the health field in India, you
Srinath,
need
I
to
just
have
remember
leadership
everything.
Thank you. Thank you.
You are very much, you have not spoken everything there. Or how can you? It's yourself.
Maybe the last question from anyone. Yes, sir.
Sir, can I please? Sir, I'm waiting.
Yeah, after Dr. Vasne. Yes, please.
Sir, very good evening, sir. Sir, I'm Dr. Vashne. I am right now Executive Director, AIMS Devgar. I'm an ENT surgeon. I have, sir, 3 basic questions to you.
Sir.
First is, sir, I had an opportunity to contribute to formulate the National Program on Prevention Control of Deafness 2006. So we were 6 people who formulated, which got into a national program and is part of. I'm not trained MPH. Should I call myself a public health advocate? Because, sir, there is a lot of debate goes on in academic circles that I conceived that program with the team. I was a state nodal officer for 11 years. I lived with that program. And today I don't have time for the program. So that program is the first national program on deafness launched by Government of India. So should I consider myself as a public health activist? My first question, sir.
Absolutely, sir. I don't think there is any qualification that is required to
But
play a
sir,
public
in
health
academic
role.
circle,
Well,
because they say that,
no,
that one has to have a degree of MPH to call yourself as a public health worker
Not
or
necessary,
public
not
health
necessary,
activist.
not
Because sir, this has
necessary.
been, I have faced this number of times in my career.
Sir, the question is whether you have had formal academic credentials or not
Yes.
is relevant to maybe teaching, but even that also is no longer necessary. People are talking about professors of practice. UGC has brought in professors of practice from industry into business schools and from people who are actually leading programs into medical colleges or schools of public health. So I don't think even academic credentials, it matters that much. But certainly in terms of advocacy and implementation, I don't think it should matter, sir. If you look at who have played major roles in public health.
So my second
Many people have played. After all, if who did the work on rotavirus vaccine in India? M.K. Bhan, pediatrician, not formally trained in public health.
Correct, sir.
There's many others like that who have done things like that.
Okay.
Much of the work in childhood diarrhea, etc., but also in other areas, and we have seen pediatricians, obstetricians taking lead. I do not see any reason why anybody who is actually undertaking public health research or public health advocacy should necessarily be burdened with having to produce public health academic qualifications.
So my second question in the continuity of your career graph, what you mentioned, that the country was fortunate. People like you had an opportunity to be trained under INCLAN, and you trained yourself as a public health worker, epidemiologist, and you got a training, and you could do what we are hearing from you out, your excellence. But what is happening, what Madam was saying, that continuity. So what happens, because I am doing 2-3 projects. One was union, big projects on tobacco we have, advocacy in Bihar and Jharkhand. So when we sit on a platform,
Dr.
Sir,
Please come to the question.
sir, I'm coming to the
Because there are
question.
many
Sir,
other
so
people
when
waiting.
an MPH person who does not have a medical background, they are sitting on the panel dais, and I, being a head neck oncosurgeon in the field for 30 years, they tell us what to do in a program. So that is heartening, sir. Because we have been 30 years advocating our patients quit, and all the modalities they've used, and a person sitting across the table with 6 years of experience, non-medical person trained into, and they tell us what to do as advocacy in tobacco control. So that is what I think Madam wanted to highlight, because there is a, sir, I think a bridge has to be created somewhere. So one small point, sir. Sir, can any proposal can be brought, sir, by people by level head? Because, sir, fortunately, our institute president is Professor N.K. Arora, sir. So we are very fortunate, and under his guidance, we have started School of Public Health. We are starting integrated public health course at our institute from July. So we are starting it because under his guidance and leadership, sir. Sir, can there be some provision that clinicians, they are not given MPH, but they are trained somehow during service into public health intricacies or epidemiology, some online module course, because these days online courses are very much recognized. So something can be done like that by, say, PHFI or Government of India, something like that you can suggest for, so that clinicians also come into mainstream of public health. I think that will be a big shift for the country, sir. That's my suggestion.
Sir, certainly, I do not see any reason why it can't be done or shouldn't be done, sir. When we started off, the first program was actually a diploma in public health management, which the ministry wanted us. They said people involved in district and sub-district level health programs should be trained both in public health related issues as well as in managerial functions, because that's an important element as well. So it was a hybrid program that was developed, and initially it was meant for people sponsored by the government from health services, but then it became open to others as well. Now, there is no reason why we cannot offer. Even now, some online courses are being offered. Given the fact that many people who are practicing clinicians or practicing health administrators may not have the time or get the leave to come, online courses are being offered, and it's entirely up to the aptitude of the person to register and get the course. But even otherwise, there will be some methods, some workshops in clinical research methodology, which is nothing other than application of epidemiological principles and biostatistics. Those are being done anyway, including for the National Board of Examinations, where it's necessary. So some of these are available, sir. And Professor Sanjay Zodpe is currently the president of PHFI. I'll pass on the message to him. We'll be happy to collaborate in any manner required. And just to reassure you that there are no artificial divisions. Almost every director of our institutions, out of our 6 institutes of public health, 4 of them are people who have done community medicine and have been in the leaders in departments of community medicine. So we don't see any division at all.
Can we move to our friends who are online? They've been waiting patiently. Yes, please go ahead.
So Usha Venkatachalam, your students from Chandigarh. I did training in McMaster, the MSc in McMaster. Remember, you had recommended my for you is I work on gallbladder cancer prevention. So gallstone is an important risk factor. I have to take ultrasound to the community, but the PNDT Act creates a problem. How do I advocate?
This is a problem that many people are facing in terms of applying ultrasound in the community level because of the PMDT Act. We will have to really advocate vigorously now, perhaps with the help of the ICMR as well, because Dr. Rajiv Bahal is there. We'll have to talk to him and see how exceptions can be made. I think now they do permit government hospitals to take the ultrasound machine to the
that's right.
mobile van. Yeah, they're allowed by government hospital, but in non-government medical colleges are finding it difficult. So we'll have to talk to them and see how best we can actually get these mobile vans to go even from other institutions.
So is focusing on people who are more than 50 postmenopausal a way to go forward quickly?
Well, given the fact that gallstones are probably more likely to be found in that population, 40 plus. So basically, I think you can start there, but if you're really looking at getting the rules relaxed, because one of the problems is you may say that you're focusing on, but the person who is giving you the permission may say that the van may be misutilized for other reasons. So I think we must get some general rules fixed which are available. I mean, even for doing echocardiography in the field, some of our colleagues like Professor Anita Saxena and Professor Krishna Kumar have had difficulties. So, but they've had to obtain special permissions. So we'll have to negotiate with ICMR and Department of Health Research to try and get these rules modified.
Thank you, sir.
Dr. Satish Kumar, and we will take 2 more questions and we'll finish. Otherwise, this will continue. It's already 5:30 plus.
Well,
Yeah, let him finish, then we'll come to you.
Yeah.
We'll come to you. Let him
I mean, just like to say that I only wish that we could have many more inspiring leaders in public health like Dr. Reddy. I mean, I'm fortunate to work with him in the community control of rheumatic fever, rheumatic heart project, which he referred to in early 80s. Now I've got 2 or 3, observations and questions. One, of course, is that there's no point having multiple schools of, public health. I have no objection to that. That's what when we're formulating the national policy, we debate on that. The only problem is we should not compromise on the standards. So as a group of academicians, we must try, and this is a question, an open question to you all. There will be 1,000 schools, different parts of the country, let them. But then there has to be a common, exit examinations, whatever, so that the standards are maintained. And that holds true for medical colleges as well. keeping in view the mushrooming of the medical colleges. That's one point. Second point, which I would like Dr. Reddy to consider is, it's good to have public-private relationships. But somehow, what the
Dr.
last...
Satish, do you have a question?
I have a question.
Okay.
The question is that we have learned in public health discipline that health is a public good, whereas private sector always considers it as a commodity. Now, how do we strike a balance? That is my third question. And there's another question for the leader, that how are we going to protect our national institutes? When I was working with Dr. Reddy, there was famous, for benzathine penicillin, you could go to Lucknow IDPL, splash down. All these national laboratories, they have been reduced.
So the question is, how do we protect institutions in India?
National institution, how to brainwash, private sector not to consider health as a commodity. And third, of course, is how to maintain a reasonable level of standards in MPH and MBBS.
Yeah, your question is well taken. Can we have ladies before we come to Dr. R.V. Kumar? Rekha is your name?
Yes, sir.
Yeah, please go ahead.
So my question is, sir, for all the NCDs, sir, or for all the NCDs, I think obesity currently is the most important cause. And like the health programs, like for pregnant women, I see more attention is given to gaining weight rather than reducing unnecessary weight. And another one thing is that, so like you are in close contact with the government. When we don't advocate for better space and parks for exercising and all, how public is just telling ki exercise karo, nothing is going to change actually.
Thank you. We take the last question and then you can respond to all three together. Dr. R.V. Kumar. Okay.
Now, this ultrasound business, we have a Think Bus cancer screening program in which ultrasound has been approved, and we take it to community and screen for abdominal cancer.
Yes, sir. Even for congenital heart disease and rheumatic heart disease in children, the Amrita Institute as well as Professor Anita Saxena, when she was at All India Institute, they obtained special permissions. So in the national program for cancer, of course, it's possible. But there are restrictions. We'll have to definitely try and work around them. The questions that have been posed are standards. I think it's absolutely important that standards should be set across schools of public health, across medical colleges where new schools are being started, universities where new schools are being started. Now IITs are starting schools of public health. Indian Institute of Science is starting a schools of public health. It's important. But I think one of the things that Public Health Foundation of India was asked to do when the mandate was given by the government of India was to try and set up an accreditation system. Of course, in consultation with others. But we could not do that because we did not have a university status and we could not start our own degree granting. We were only focusing initially on diplomas. And the degree granting powers took a while to come. So we thought that let that be convened at some point in time. But I think at the level of the Ministry of Health, there have been some consultations and some sort of standards have been prescribed. And Professor Zodpe is pursuing now, again, with different agencies to try and convene a group which can look at how the standard setting can be done. But interestingly, we'll have to be careful about how rigid the standards would be. Sometimes because the situation is evolving, we have to be adaptive also. Just to tell you that why rigid standards don't work. The Association of Schools of Public Health in US, they have very set standards for their curriculum. And they recognize schools within US and within Mexico also. And they've given membership. But they did not give membership to the London School of Hygiene and Tropical Medicine because they have a particular insistence on environmental health being an important component. At that time, London School of, and for them, for the US, environmental health means a lot of occupational health. And the London School of Hygiene and Tropical Medicine said, we don't accept your definition, so we'll not say that we are teaching environmental health. So interestingly, the LSH team was not given recognition by the Association of Schools of Public Health. So we'll have to be setting up standards, but not in an extremely rigid manner. That is something that we must look at. The second question was on, you said public-private partnerships. We do not collaborate with the industry in terms of any conflict of interest. We were mostly taking support from non-medical industries, information technology. I mean, people like Rohini and Nandan Nilakani, Narayan Murthy and others, and Shiv Nadar and others, they are the people who contributed mostly to the growth of the institutions. When we deal with the industry, we have to be very careful about conflict of interest, though sometimes people may come in with clear-cut intentions which are not necessarily against public interest. So we'll have to really decide what is public interest. So I define PPP not as a public-private partnership, but as a partnership for basically advancing public interest. So what is public interest is something that we'll have to really identify and say if they can contribute in that manner, that's fine. You cannot completely stay away from the private sector because they're there everywhere. But we have to be very clear that our principal stand is not compromised. Then third thing, of course, is you raised a question about protecting public institutions. Of course, that's absolutely important. That depends on leadership. That's what you're really looking at now. So if you create the right kind of leadership who have both the caliber and the commitment, and also, if I may say so, the spine to defend the institution. They must have the courage to defend the institution. That's a very important element. I've seen people in All India Institute who have vigorously defended any intrusion into the autonomy of the institute. So that is where you must actually build that kind of a caliber of leadership. Then the other question was on obesity, I think. One question was on obesity. Well, ma'am, basically, I agree that obesity is an important problem, though the way obesity is defined should not be, again, constrained by the conventional definitions, because it has been mostly taken on the basis of BMI, which is a very inaccurate measure for the simple reason that it measures certain aspects of body weight in relation to height. It can be misconstrued. It doesn't actually measure just the body adiposity, but it brings in bodily muscle mass, it brings in the bone weight, and therefore you can have a person who is very muscular who can have a high BMI, and you can have a so-called thin person with a lot of body fat, particularly if it is in the abdomen, visceral adiposity. Then you can actually pay all the metabolic penalties of obesity without appearing to be fat. So obesity, now even worldwide, people are now beginning to question BMI and throwing BMI away. They're really talking not only about that, for example, waist-height ratio is coming up as a more important measure of body adiposity, and which also captures the element of where the body fat is distributed. So because the waist-hip ratio is difficult because hip measurement is not always easy. Waist-height ratio, which was originally developed for children, is now being increasingly adopted. If you look at the NICE guidelines in US, the National Institute of Clinical Excellence, they've actually adopted waist-height ratio as the measure rather than the other measures. So we have to really look at how we are defining obesity because we know that 1/3 of the diabetics in India are thin diabetics. That's because of visceral adiposity, not because of high BMI. So we have to focus a lot more on how we identify the metabolic risk of body fat content and body fat distribution pattern. But certainly that becomes an important element in the Indian context. Now, you had said that there is a reluctance to undertake physical exercise. That is something that we'll have to try and make people not only understand at the individual level, but create conditions where they can exercise with pleasure and safety. If our roads are not built for safe walking or safe cycling, it's going to be very difficult. If we are not protecting community spaces where people can exercise or walk, then we are actually creating difficulties. I remember there was, when I was very much in All India Institute in Cardiology, when I told somebody from a relatively affluent part of Delhi that she must go for walks and do a little exercise and go for walks. She said, "Doctor, if how can I go for walks when either the air is very polluted during the day, or if I walk early in the morning, I'm not sure of my safety because there is crime." So anyway, we have to actually create conditions where people can do it. Of course, if people have the will, they'll do it even at home. But it partly depends upon how well we can communicate the message, but also create social conditions which make it easier for them. Right now, many people are saying, why should I walk outside, even in the gardens, when air is so polluted? I will have to face the penalty of pollution. So we'll have to remove some of the barriers before we can tell them. But certainly, I think the advantages of exercise will have to be pointed out, and physical activity has to be made an important message. And in schools, in particular, that's a major challenge. And even in worksite settings, we must encourage physical activity as a part of the routine. So those are things that we must undertake. Then there was a question about, I think those are the questions that I...
Thank you. If there is somebody who has a question in mind, if did not ask this question, रात को नींद ही नहीं आएगी. Is that okay? Okay. I will summarize in one sentence. You said public health and curative medicine is a
Sir,
who's that? Okay. So go back to your undergraduate days. What is prevention? Health
Sir,
promotion, specific protection, early diagnosis and treatment, and disability limitation, and they are all 5 parts of prevention. So don't forget that early diagnosis, if you do, you prevent. Then you do the disability limitation, you prevent disability, and rehabilitation, you put the person back to life. So that what we were taught in undergraduate is very particular. Usha ji, you were having something? Okay, over to Dr.
One suggestion, sir, like the army people. Sir, the army people have physical fitness as a part of their promotion, as a part of their entry. In all other jobs in India, we don't have physical fitness. So we should introduce that as a component. It will make it mandatory for people to be physically fit.
Well taken. We have 2 ex-army people in the room and they support what you said. Over to Dr. Umesh Kapil.
Thank you.
Respected Professor Srinath sir, on behalf of all of us, we express our most sincere thanks to you for sharing your life story, how you took the right decision at the right time. Continue with your commitment. That is the most important thing. Never get distracted because of the distractions. That's something very important. Keep your focus in mind. Your story, life story is very truly inspiring to all of us. And what you have achieved is something remarkable. Listening to you in Brazil or some different parts of the world is always a pleasure. I must end by saying that to be a good leader, you have to be most humble, most polite, most pleasant personality, and then most articulate. then only you have some of these are attributes to be of a good leader, apart from many other attributes. And sir, you all have all these things. Thank you very much, sir, for sparing your time. We are grateful to you. Thanks a lot. Tomorrow morning, at 9 o'clock, we have Professor N.K. Ganguly, who was the secretary and who was DG ICMR, one of the best scientists we have in the country. Please do come by 9 o'clock. Thank you.